See, very good. So now they'll be listening to me more than anything else. Are we ready? We are ready to rumba. Now, so we'll get that done. I have a modest proposal. How many people are going to be here tomorrow at Friday at class time? Would you like to have the afternoon off?
Yes.
Yeah. I have to give tests here anyway. I have a 12 o'clock and a 1 o'clock, and I figured after that I won't even be in the mood to do anything. So why don't we say you could have an hour's head start on, because I figured we might not have great attendance tomorrow. You'd be here.
You're my only class on Friday. What am I going to do?
Oh, I don't know what to tell you. And you were going to come in for just sleep after work. I would. So after today, and I'm sure I'll see you around in some juncture. Have a wonderful break. Enjoy. Bonsoir. Happy dance. Be careful. I regale you with stories about what my kids did on break, but so I only have one who went to college, and he was busy with ROTC stuff on break. All right, back to work. This is the clotting one. So we looked at the red cells, the white cells, and again, my apologies for not. I got Mrs. Maurer ordered those Lancets for me. We'll be set to do the blood lab on our return. Kenzie, I'm glad you didn't miss the blood lab. Pardon me? You don't have to, but you can observe. You want to prick your finger. Oh, then I'm doubly happy that you'll be here for all of that. Moving on. So we've covered red cells, we covered white cells. This is platelets. So platelets effectively are, again, we use formed elements because they come from, it's interesting. They come from a cell that keeps replicating. So think of mitosis without cytokinesis, if you want to think of it that way. So you get this mega cell that keeps increasing in size, has all the internal ingredients, and what effectively it's almost like it's being passed through like a little strainer, and these little fragments. It's kind of the way bone marrow works to a certain extent. There's wonderful reticulin fibers and stuff, and it strains out, and these little fragments of membrane with granules, with protein-based granules, and effectively that's what a platelet is. So it's a cellular fragment from this very large, giant, not just a giant cell has a different connotation in white blood cell land, but this megakaryocyte, this immense cell. And the granules typically stain purple in the typical dyes that we use, and a lot of the chemicals. So it has a variety of really important things. Serotonin plays a pivotal role in constricting blood. Basically, they're there for damage. And one of the things when it releases serotonin, it will cause small blood vessels to constrict. Calcium, which plays a pivotal role in the clotting cascade, as do all the enzymes. ADP, and again, also playing a role in the clotting cascade. And this very interesting chemical plug, you'll see the initials PDGF, platelet-derived growth factor. It's kind of interesting when we see with platelet-derived growth factor. It almost came. We now call a lot of things growth factors that we didn't really have a name for. We knew they were proteins or polypeptide in origin, and we began to discover them. The first one, and you may remember me talking about this when we did the nerve unit, there's something called nerve growth factor, which we identified how the cut ends of axons will actually secrete this chemical and it'll cause them to grow and seek ends out. And nerves will actually grow. If they're in close enough proximity or held in close proximity, they'll grow back together. This is another one of these, and there's more than these. So this platelet-derived growth factor, we used to see that using blood and blood products in wounds really would help them. So fascinating thing was they began to isolate what was in there. And what one of the linchpins for ages on wound healing was platelet-derived growth factor. Because inevitably, when you had wounds that were persistent, you had epithelial tissue and connective tissue, and platelet-derived growth factor did a tremendous job in accelerating the development of those, and that basically closed over wounds. And whether or not it's being used as in wound healing clinics today, but wound healing clinics developed because of the particularly platelet-derived growth factor. And if many of you are like me now, what do they inject into people's knees? Athletes. They're wearing a Yankee outfit today. What did they just give to Giancarlo Stanton?
I'm wearing it, but
You're not a Yankee fan.
no, that's not true. I am marrying into it.
You're marrying into a Yankee fan.
Yes, very much so.
God bless them. I'm waiting for the invitation. I'll wear my Yankee outfit. Okay, Giancarlo Stanton was his elbows. Okay, and what are they injecting with? Platelet derived, basically called PRP, platelet enriched plasma, PEP. Exactly. And so why are they using the platelets? Platelet derived growth factor. So they found that it may not be specifically that platelet derived growth, but they do find in platelets that there are factors that have been a useful alternative to having operations. Because if you're like me, I've been a Yankee fan only since I'll get there. Since, I don't know, 1957. So a while ago, like the better part of 70 years, Garrett Cole is out for the season. He's got to have Tommy John surgery. Yes. No, they're different. Steroidal injections are basically anti-inflammatory in nature. They don't do a lot to promote healing. If anything, they may interfere with healing, but what you're trying to do, when you use that, it takes away inflammation, which takes away pain, and then you can do rehab. One, you can participate, which they do with a lot, but you can do rehab at the same time. So and the trouble is there's sort of like a law of diminishing returns. You can't use them that often. It's very temporary. They have a short-acting agent and a longer-acting agent mixed together. But maybe typically you wouldn't want to. Now, professional athletes different because they're getting paid a lot of big money, and so they realize that. And the military, it's the same concept as the military. If they want to give you a shot, they're giving you a shot. Let's be clear. Hey, you know that as well as I know that. If my son telling me he's going to Cambodia for the first time, my arms are going to fall off in a zillion shots. But what happens is that maybe 3-4 times, if you have grandma's knee, that's a mess. Maybe 3 or 4 cortisone shots a year, and you're less worried about her. But a young person, you really are concerned that if it's not injected properly, it can weaken tissue. It can cause tendons to rupture. So it has to not only have to be a limited injection, but it has to be limited vis-a-vis very precisely administered. So you got to know what you're doing with those things. Like for Achilles tendonitis, they used to do that and cause Achilles tendon to rupture. Problem. So the alternative, to bring it back to point, was this platelet-enriched plasma, which a lot of athletes have done, not always working, because they're all different processes that are there. So what happens is platelets form these little plugs that seal breaks. And when we think about blood clotting, we make a mistake. We think, I cut myself, and now the blood's going to clot. The vast majority of your clotting activity is something you know nothing about. It has nothing to do with a physical injury. It's not because you cut yourself or you skinned your knee or you some big accident or some major trauma, or heaven forbid you were in a traffic accident or got cut or got shot with a stray bullet or anything like that. Those kinds of things are comparatively rare. Yes.
Does bruising cause like clotting as well, or?
Bruising causes blood to extravasate, to leave the blood vessel. there certainly would be some clotting that would occur. It's not, bruising would not necessarily induce clotting. It's more, it would on a very microscopic basis. Either way, and it's kind of what I'm describing here. If most of the clotting that we do, everybody, are, we have if thousands, if not hundreds of thousands of miles of blood vessels in our body. They get wear and tear. They get potholes. They get irregularities. They need to be resurfaced. Just like, think of it as any group of roadways. And I mean, we live in a state that's the poster child for rotten roadways. We live in pothole central. And effectively, that's what the clotting cascade does. It's called the intrinsic clotting system. Basically, it's a series of events that occur to treat these little divots and imperfections that occur in our myriad of blood vessels. Okay, it's a system that is active all the time, works relatively slowly comparatively. We're talking about minutes versus what's called the extrinsic clotting system, which works rarely, hopefully, unless you're really injury prone, but very, very rapidly. Because inevitably the source of the damage is typically a larger amount of trauma compared to some tiny microscopic arterial or capillary that has a defect in it, comparatively speaking. What makes it intrinsic, all the factors that allow the clotting to occur are within the blood to start. What makes it extrinsic is that when tissues are damaged, and now we call it tissue factor, we used to call it tissue thromboplastin. Tissue factor is now the term. It's something that is a chemical that is released when cells are damaged. That's the definition of an injury. Cells are damaged. Whether it's on interior or exterior, that tissue factor will accelerate the clotting cascade in such a way that it will happen rapidly. So we're talking not minutes, but seconds. So this is basically what platelets typically do. This is mostly in reference to the intrinsic system, though they're also activated by the extrinsic system. They form these temporary plugs that seal the blood vessels. Good old nitric oxide, you keep seeing more and more reasons why nitric oxide is relevant. And another chemical called prostacyclin, all of these, so as blood's flowing and exerting any type of force or pressure or stretch on these little blood vessels, these chemicals are released. They keep the blood flowing properly. Platelet formation is regulated by something called thrombopoietin. Okay, this is something that when we need, in other words, we need more, like erythropoietin, you need more red cells. Okay, if you need more platelets, basically it's a negative feedback system. They start in the myeloid line, the granule, because they're filled with granules, remember, called the megakaryoblast, becomes a megakaryocyte, mitosis, but no cytokinesis, this giant cell, multi-lobe nuclei, and little cytoplasmic projections kind of strain through this array of reticular fibers that are in the bone marrow, and they break off into little fragments. They don't last very long, but you have a lot of them. So typically, nowadays they give you a platelet count on your blood. Numerically speaking, years ago we used to say platelets adequate. We get a CBC, a complete blood count, and you look at our platelets adequate or inadequate. Basically what we say. Now they give you the count. So here's this cell getting bigger and bigger and bigger, and then your little fragments. And they're just showing you in relationship, size, and numbers to all the other things we've already covered that were there. And so all of these are tied to, sir.
Size of the platelet. I remember my internship, they were
Yeah.
platelets.
Yeah. Short answer, don't know. Don't think so. Interesting question. But only remember this. One day, when I ask you to email me and ask me to look that up. But it'll give me something to do when we're away. Like I don't have enough to do. We're always starting to refurbish the deck. Got my car back finally. Which thankfully is, I told you, the guys in Oakland, in Oakmont rather. So we went to, you guessed it, Oakmont Bakery stop. Happy days. My wife and I go, she said, we each can get one thing, that's it. We're gonna sit here and savor it. Fortunately, I have to bring the car back. You forgot to put the inspection sticker on. She's happy about it because we get to go back to the bakery. Yeah, you got to take there's positives versus negatives. Okay, so what happens is this. Let me go fast. So any tissue when it's injured responds. Even a tiny blood vessel will spasm. Platelets, effectively, that defect exposes underlying collagen. Under any endothelial layer or epithelial layer, under any lining layer, there's always loose areolar connective tissue. That's where the collagen is. The collagen is exposed, the platelets form a plug, and effectively they coagulate, they clot. So the vessel, any injury, and so we use it, we think injury, oh my God, poop. But the reality is that defect is a quote unquote injury. In this case, it's a wear and tear, a usage injury. So the direct injury, it could be to vascular smooth muscle, it could be chemicals, it could be pain reflex, they'll all trigger that spasm. That's part of that happens with regard to how that defect started. It's much more effective and smaller than in larger vessels. I mean, if you're dealing with a big name vessel, femoral artery, radial artery, you got a big problem then. If a defect is formed in that, because something bad is going to happen after that. And again, significantly reducing blood flow until other mechanisms come in, shutting down that line, redirecting it, etc. Collagen fibers that are exposed, platelets do not stick. It's that lining. Again, I do it again and again. As illustration. It's all about being smooth. Things don't adhere to it unless by intent that are there. And then there's other factors that are involved. The prostacyclines and the nitric oxide keep it from sticking to each other because they're there. And and this is interesting, von Willebrand factor is important in stabilizing those clots. And I may have mentioned it to you. My first wife, they found out that she had a variant of what's called von Willebrand's disease. It's a disease that involves that factor. And the only time it demonstrated itself was normally she clot like you and I would clot, normally without any problems. But when she had surgery and they did a couple of ovarian procedures when we were trying to get pregnant way back then, she ended up with a big internal bleed and had to get a couple of transfusions. And my guess is that's when they exposed her to hepatitis C, most likely. This was back in '81. And the other flip side of that was then we did a work. They didn't know what it was exactly, but they had a workup. I mean, her surgeon was absolutely horrified at all this had happened because the surgery went so well, and to have this really significant bleed that put her at a certain degree of risk for at least, maybe a few hours. And so we went to the blood bank, and at that point they did a zillion blood tests, and they finally came up with it and she had to do. Remember I told you about the antidiuretic hormone that injected? She had to inject that because it accelerated the clotting. It made up for the absence of that. She had a mild variant, so the platelets swell. Once they smack together, they're activated. They adhere to the collagen. They swell. The ADP, which is in there to start with, more platelets to stick. The serotonin and thromboxane A, they increase the spasm. That's what serotonin does in these injuries. Part of that, what happens in injuries, think of it as protective. This is that oddball. This is the positive feedback. So it's going to do that. As more platelets stick, more chemicals, more platelets, etc., etc. And it's designed that way until the defect is sealed. It's a small defect. So it's great for tiny vessels. It's not great for big vessels. So when you're dealing with a larger vessel that's having an incident like that, most likely there's been some type of significant trauma and you may have to, and you may require external intervention, like having to go in there and repair a vessel, what they might be referring to. So the actual act of the platelets aggregating and sticking together and activating reinforces it and releases the fibrin threads. The whole idea of the clotting cascade is one thing. It's basically changing fibrinogen into fibrin. That's all it does. So you have to dissolve soluble fibers of fibrinogen, and the whole idea of the reaction to make them into fibrin. And that's really where the clotting cascade leads to that step. What it does is it creates a chemical called thrombin. All of these chemicals, all of these proteins effectively are in their inactive or ogen stage. So what happens, all that clotting cascade, once it's activated, basically it creates a catalyst to change the precursor, prothrombin, into thrombin. And then the thrombin will catalyze fibrinogen into fibrin. That's the clotting cascade. But nothing special here. It's all a series of inactive proenzymes that are activated when we need them. If they're activated prematurely, then you have people who clot irregularly for whatever reason. If there's a genetic defect, or if there's a defect related to nutrition, if there's some other disease entity that they don't clot sufficiently, that's on the other side of it. So for most of us, it works just fine. You clot when you're supposed to. So again, reinforces the platelet plugs. Blood clots are effective even in sealing larger vessel breaks. So it just depends. If there's a sufficient amount, unless it's something that's so large that you have to take additional steps. And effectively what happens, the blood, obviously liquid, what the clotting does, and initially, it's fascinating when you start to know about this. Next time you cut yourself or you take a little gash of skin, what happens? You can watch it as it clots up. That first thing is it bleeds. When the bleeding stops, it gets kind of that gel-like, and then it begins to dry and harden. And then voila, magically, eventually, if we don't pick the scab, they used to, basically what your mom always told you, don't go picking at it. And you let it fall off naturally, voila, you're better. Yes,
Why is it that the scabs are itchy when there's
inflammation.
Is that?
Inflammation. Anytime there's an injury, there's inflammation. White blood cells are always going to be called to the party. And we'll get to that with the immune system.
Yeah, but if it's bad to take it off, why is your brain telling you to take it off?
But it's not your, because it's inflamed. It's a measure in self-control. We do, but when they have a lot of patients in a hospital or nursing homes can't help themselves. So, and you can't restrain anymore like you used to in nursing homes. If you get familiar with geriatric, so you trim their nails very short. Sometimes you get them to wear gloves at night. I mean, there's all sorts of little tricks that you try to do. Because you really can't, there's no reason to restrain them legally speaking.
Like airplane where they're like, get a hold of yourself.
Exactly. Blood is transformed from a liquid to a gel. So this is all the clotting factors. We do Roman numerals. It's around the test. If you don't know your Roman numerals by now, I can't help you. And don't, I mean, how hard is it? There's been enough Super Bowls. I've seen them all. Except the first one when I was in a plane going to Vegas. Not the first one the Steelers were in. On my way to Vegas. They're numbered 1 to 13, okay, in order of discovery, fine. And the 4 of those factors require vitamin K. You can't miss that because K is for clotting. And C is for cookie. Okay. And here it is. So they're just showing it to you. The damage, even whether it's visible or even just a little divot or indentation, there'll be spasm, collagen fibers, blah, blah, blah. Here we are. Very pretty. Do a great job. Here they are. companion pathways. One has multiple steps. One has a more limited number of steps. All roads lead to factor 10. Okay, so the intrinsic, because all the factors are already in the bloodstream, versus extrinsic, the tissue factor is not. Okay, series of what they call procoagulants. The pathways cascade toward the end with the activation of factor X. 10, not X. It's not like formerly known as Twitter. That could be the factor formerly known as Twitter. I thought that would be clever, but apparently that fell on deaf ears. So factor 10, and note, you're going to see calcium plays a big role. Okay. Calcium, another platelet factor, factor 5, and it forms the prothrombin activator. That's the one that takes prothrombin. That's the catalyst for prothrombin to thrombin. Intrinsic, they're in the blood, negatively charged surfaces, activated platelets, collagen, and this is what happens when you take blood out. If you take blood out and put it into a tube, it will clot. So the glass tubes that we use, basically the different color top tubes, when you're taking out blood, when they don't, sometimes you want the blood to clot, sometimes you don't. You'll put an agent to prevent the clotting in some of those tubes. Some have nothing in them. Red top tube, the most common tube that we use, has nothing in it. And lab people, that's what they know. Oh, I'm doing what's called a PT and a PTT. They'll have a blue top tube. I forget what's in there. Sometimes a CBC, it'll be a purple top tube. So you want to prevent it from clotting. I think they put EDTA. EDTA. You're familiar with that? Your biochem people. It chelates the calcium. And the calcium is required for clotting.
But you can't unclot. It's a poor pool.
Pardon me?
Like you can't unclot the blood. So like if you get a bad, I forget what their job's called. People take the blood. If it's already clotted, they clot it and do it again.
You what?
The purple tube can't unclot the blood.
Right.
It just stops it from clotting.
So yeah, I mean you're because you don't want to take away those factors because you're actually using it to evaluate certain bleeding studies.
Yeah.
That's where there's a reason behind all of those. I mean that's now you're talking about somebody who's teaching laboratory technology and the science behind it, not me. I'm sorry, I can't know everything. I have children who have fought with that idea. How many times have I gotten calls from bars? What was Mickey Mantle's lifetime batting average, Dad? What do you need to know that for? We're having a trivia contest at the bar, midnight. Usually we're sleeping. And I'm like, I'm surprised you don't know that. None of you do that to your father, do you? I get a lot of that.
My dad was all like 70s, 80s, and 90s music. That's every single thing.
Every breath you take.
He can hear like the
Yeah,
first second
too.
of any song.
That's what we did. Mine are a little older. And we used to play that game. If you like the first couple of bars and boom, you had no song. Sometimes they sound alike. Okay. So moving on. So extrinsic outside tissue factor used to be called factor 3. People see typically a tissue factor. And why is it faster? It bypasses the steps. You don't have to memorize this. If you're going into a medical school program, you're going to have to memorize this. You do what everybody else does, unless you're going to be a hematologist. You forget it, and then you look it up when you need to. So intrinsic, basically, notice what happens. Basically, that pathway starts, once the platelets release their initial compounds, they activate, takes factor 12, is inactive, activates it. The activated factor 12 is the catalyst to activate factor 11. Factor 11 and factor 9. Factor 9 also works with activated factor 7. Factor 7, okay? And notice the role calcium plays here, here, in other areas here. The calcium then will activate factor 9. That will then in turn lead to the activation of factor 8. And as you can see, 9 and 8, both in their activated forms, complex, and they activate factor 10. And here the tissue factor, along with calcium, activates factor 7. Factor 7, again, now it forms its own complex, but notice the number of steps. I mean, you have a number of enzymatically based steps here that one makes the next occur and the next occurs. Here they don't. Bottom line is all roads lead to factor 10 without going into the intricacies that are there. Once factor 10 is activated, you can see what happened. Basically, and you can see there's other things like a phospholipid surface and more calcium, but that's the prothrombin activator. That changes that prothrombin to basically prothrombin to thrombin. And you can see there's other places that impact that. Okay? So whether it's a phospholipid surface, whether there's calcium in the area, whether it's the activated factor 5, all play a role. So, effectively, all roads are leading to this event without going into the intricacies of the role. So you see a number of steps on one side, yet they're all leading in the same direction. Activating the thrombin, so prothrombin makes thrombin, factor 2 to factor 2A. Okay, and what happens then, the thrombin converts the soluble fibrin into the insoluble fibrin, just a subtle change, and you'll see it. Here's the perfect illustration. So again, one of these great illustrations. It's a fishnet. I mean, it isn't as necessary. You don't see you. I don't think you until you actually see it to understand what it does. That fishnet traps red cells, and then the combination of the fishnet, the proximity to the red cell, other factors create that gel and really conceal it. I mean, I think it's just brilliant the way it looks. There's something I mean, it mimics what we've done in real life. I think I love illustrations like that. So there's prothrombin making thrombin. Thrombin converts it to fibrin. Fibrin strands form the basis. The fibrin causes plasma also to be gel, which will make the gel, because plasma still has a fair amount of proteins in it. Those clotting factors are starting to sort of come out of the solution to a certain extent, and they catch more of the formed elements. Calcium activates. This is important. It isn't just enough to make the clot, you have to stabilize the clot. And so the calcium, along with factor 13, cross-links it, strengthens it, stabilizes it, so it's not fragile. And anticoagulants are factors that normally dominate in the blood to inhibit coagulation. So we have those. That's the role of like the nitric oxide and the particular prostaglandin type factors that are located within there. So this is sort of all the events take it to this, and eventually, so you can see all the design. What's interesting, okay, even though both factors are the same way, once the clot is there, very, very shortly after that clot forms, we have to find a way to get rid of it. If not, I mean, there's nothing here that says, well, how do we get rid of the clot? Does it just stay there? I mean, there's nobody inside your blood vessels picking it off, despite what your mom told you. Okay? There's nobody in there. So the whole idea is we have a clot busting system that's initiated 48 to 72 hours. That involves yet more of the clotting factors. If not, all the roadway repair, every time there was a road, the road would be impassable. And if we couldn't remove the clots in those impassable roads, eventually we couldn't get blood through. And structures are going to die through the absence of blood supply. They all have names. Basically, you don't have to worry about it. But you can see factor 8, hemophilia A. Factor B, hemophilia B, factor 9 rather, hemophilia C from factor 11. And so I remember students were asking me about this presentation. You can pick a disease, you can pick a medical condition, you can pick a physiology, you can look at the events at the neuromuscular junction. You can pick whatever you want to pick as long as we preferably don't duplicate it. Okay, unless it's something that lends itself to having more than one view, because you can look at different aspects of it. Run it by me. That's all. I mean, like I said, if you have a genetic disease that's interesting to you, okay, it's not just enough to tell me the genetics of it. Oh, this is autosomal dominant or sexually recessive, but we need to know what happens after that. What's the physiological basis? That genetic defect doesn't allow this protein. This protein is important in forming the neuromuscular junction. This protein plays a role in the metabolic pathway that makes myelin or whatever. Just throwing that at random. So that's, I mean, you need to do that. And if you've got one you're using for a presentation in another class, it's okay with me. I do not mind if you do, you can do double or triple duty. I'm all good with that. You got your research project and you can understand how it relates to human physiology. Give it a go. I'm good with that. So clots have to be stabilized and removed. So actin and myosin help to, they right away, they start to squeeze the fluid out of that. What is serum? Serum and plasma. In the old days, we used to do serum glucose. Now we do blood glucose. Serum is basically the plasma minus the clotting factors. We allow the clotting to occur. We siphon off the supernatant liquid, and that's serum. That's the whole difference between serum and plasma. Someone might ask you that. I mean, again, those are little nuggets that, MCAT exams, things like that. I don't think I would have it. And because it's retracting, the edges come together. So it starts to heal because of the platelet-derived growth factor, division of smooth muscle cells, and fibroblasts. What that's going to make is connective tissue. And then from the borders of the connective tissue, the lining cells. Lining cells just fill the gap. That's the beauty of epithelial cells. As long as they can get and lay on top of some kind of connective tissue, they're going to form. Wounds heal, if you did not know, principally from the sides. They work their way in, or if the base is relatively healthy. You want wounds to heal. You don't want to heal them over the top. You want it to heal from the bottom up, fill in that. When you have a top form, like a big scab, and there's fluid in here, not good. Because fluid-filled spaces tend to fill with bad stuff, like infection. And they cause pressure. Yes, sir.
So, like, how do doctors prevent, like, clotting from happening during surgery?
Well, meticulous repair to repair in layers. But sometimes you have a gap. You took out a tumor. There's going to be a gap. You put a drain in. You had a big abscess, big pus pocket. So you pack it, and you basically sew it and allow the packing to protrude, and you gradually advance or remove the packing. It's a good question. That's what you have. Sometimes you have to close them what we call by secondary intent. So primary intent is like for instance, somebody got a cut and you went to the emergency room, you got stitches. Or primary intent is you make a surgical incision, do what you have to do, meticulously close it, sew it back up. Secondary intent is when you let it close by itself, typically without sewing it up. Tertiary intent means you let it close. Maybe you're really worried about infection, or there was an infection, and you're worried about how it's going to close. Maybe it's going to form a fluid pocket, and you may have to do something. And when you're sure it's not and it's filled up enough, then you suture together. Primary, secondary, tertiary. Not on the test. See, that's the only way I can convince you guys I actually used to do this stuff. Oh, come on. See, but now I don't do it. Now here, this is the other one. VEGF, vascular endothelial growth factor, stimulates the endothelial cells to multiply and restore the endothelial lining. Eventually, and maybe they do it now. I'm teaching you this aspect of science. If I was teaching in a medical school, you would have to keep up with every recent development, nuances. Have we analyzed this? It's, that's the difference depending when you go to a graduate level program or if that's the direction any of you are heading in. It's just who you're going to run into are going to have a whole different array of information. Now, almost done. Process whereby clots are removed after repair is completed, fibrinolysis or fibrinolysis, however you want to pronounce it, within a couple of days. And so you have another protein that's in the clot. It's called plasminogen. And so what's activated by one of the factors, factor 12, which we activated, and thrombin, actually, even though thrombin is actually making the fibrin appear so the clot can form, it's working with factor 12, and it activates this called TPA, tissue plasminogen activator, and that catalyzes another one of these dissolved proteins, plasminogen, into plasmin. That's going to start to just basically gobble up the clot. We make that genetically if necessary. In large hospitals or in hospitals where they have a population, and now most hospitals carry it, if someone's coming in with a heart attack in progress or a stroke in progress, they will insert a catheter and inject TPA to bust that clot before there's permanent damage. It happened to an aunt of mine who's now deceased. She was down in Florida. She retired, a widow by that time. They were fortunate wherever the retirement community, they got her to the hospital. Down there, it's God's little waiting room, and boom, they got that taken. So she lived quite a few years longer. Years ago, if you did not know, they used to take streptococcal enzymes. Streptococcus have spreading factors. So when you had a strep infection, one of the things that made it spread, okay, was an enzyme called streptokinase. It was named for the bacteria. They used to inject that, but there were more problems with that. This is something we make genetically without having the problems associated with the bacteria in the manufacturer. So this is and now it's a relatively simple compound to make genetically. Yeah. And so that you're basically going to find it everywhere. Okay. So, and other things that go on, swift removal and dilution. Okay, there's a limited amount of thrombin is restricted to the clot by fibrin threads, so it doesn't get real big or escape under normal circumstances. Okay, so inactivated by any unbound thrombin that escapes into the bloodstream, we have a mechanism to deal with it. Mast cells, so part of that inflammation going to the party. Mast cells inhibit thrombin, they activate this. Heparin is basically an agent we use in the hospital all the time. When someone has a risk of a clot or to clear an IV, we call them a heparin lock. You start an IV. I had one just recently when I was having that, a scope procedure. They started the IV, they put a cap on it. When they had to go, 10 minutes later, they're taking me to the procedure room. They uncap it. They take a tiny syringe filled with heparin, flush it because little bits of clot have formed to clear it, and put the IV in there. They were going to give me the sedation material. So all of those things. So the lining is important. The endothelial cells, the nitric oxide, the prostaglandin called prostacyclin. Vitamin E basically plays a role with this as well. So a lot of people take vitamin E because it's useful to dealing with toxic derivatives of oxygen. It's very popular. That's the good news. If a patient's coming in for surgery, they will tell you, stop all fat-soluble vitamins. You take vitamin D, supplement E, any of those, you need to stop those typically a week to 2 weeks before. Same thing with aspirin products. So that's one of the pitfalls about that. Because when I was having prostate surgery, I've had, as you probably understand, I've had too many procedures. I'm no longer going to doctors unless absolutely necessary. I had it. Unless I have to get my prescription for anything. I'm trying to get rid of all of this. So the big deal here is these two things. you can look through this as easily as I can, because it's in the interest of time. I'll remind me to comment it before we start our next unit when we get back. That's all. Thank you. Goodbye. I'll see everybody. If I don't see you tomorrow, I'll see you on the flip side. Take one of these, please, if you have